Good morning, everyone. Thank you for making time to join us here this morning. My name is Paul Carson, and I am with Care Oregon in Care Oregon's pharmacy department. Pharmacy is the area that hosts our ongoing educational program for primary care folks called Meds Ed. It's called Meds Ed, but it doesn't necessarily limit itself to medications. We are trying to focus on any of the things that impact our members as they overlap into the world of primary care, which brings us all together here today. I'll tell you a little bit more at the end of the program about our next upcoming session. But I just wanted to give you a little bit of some initial housekeeping items about the way our program is structured this morning, and then we'll get started and introduce our presenters. So you will all have access in Teams to the Q&A feature that's in there. So at any point you have a question for any of us, you can go ahead and use that function. And you can put a question in that Q&A. We're going to have time built in at the end to do kind of a larger Q&A format with our presenters. So you can ask, you can save those questions till then. But also, if you have something you want to just comment on in the midst, feel free. That's good to do. And I'm always very curious to hear from folks who, if this is your first Meds Ed ever, we've been doing these since back in 2015. Had quite a few of them. Let me know if this is your first time visiting with us, and let me know where you're from. I would love to know where you hang your hat and where you're practicing care. So without further ado, I think we should go ahead and get started with our program here this morning, and I'll take you through a couple of things. First of all, let's talk about our CME. I know that's an interest for a lot of folks here. You want to make sure you're getting credit for attending here today, and we are approved from the American Academy of Family Physicians for 2 credit hours, Category 1 credit hours there, and those automatically transfer over to the Oregon Board of Pharmacy. And I've been hearing lately that those also should work for most folks who are in need of CEU credits as well. Just check with whatever board authorizes your credit, but these should be one-size-fits-all credits from what I've been told. So that should be good stuff. And I'll explain to you at the end how that works. What we do is basically send everybody who's enrolled a quick survey assessing your familiarity with the content. You just fill that out for a couple seconds, and then we'll email your certificate early next week. The survey you'll receive later today. Here's an overview of our agenda this morning. We're going to talk about the whole context of overdose, both in the state of Oregon and with our good friends at Central City Concern. All of the challenges and opportunities that are involved with supportive housing. What brings us here today is the overdose prevention project that our partners at Central City Concern have undertaken. And how is it working? What is the data revealing, and what are some of those outcomes here, and what should we all be working towards as we go forward? So it's going to make a really impactful morning. I think we're going to get a lot of really good information. I think you're going to find it will leave you feeling full of hope and optimism, which I think we all can use right now. Here's a snapshot of our learning objectives that you'll be seeing when you do get that post-session survey from me later today. Very general learning objectives that embrace the content, so should be very simple there. No concerns on that score, so you'll have those. And let's go ahead and introduce our presenters this morning. These are challenging times that we live in, friends, here in particular in the state of Oregon and in Portland. And a lot of times we wonder if we are being defined by things like overdose use of fentanyl and houselessness. We see so much attention put towards that, and the environment is so sometimes seemingly overwhelming that it can leave people feeling pessimistic about what's possible. Is anybody doing anything? I hear that all the time. Maybe it's time to move somewhere else because nobody is doing anything, all right? And it's very easy to succumb to that line of thinking, and it's very important that we are aware of what's happening and be mindful of the fact that, yes, there is work that is going on and good things can be done. There's cause for optimism. Especially when you have the good fortune to have people who are taking action like we are doing these days. Over the years here at Care Oregon, we have been incredibly fortunate to have a robust long-term partnership with our good friends at Central City Concern. They don't just talk about things, they do things, and they get things done, and they do it in an incredibly positive and impactful way. So I'd like to just take a moment and introduce our two presenters here today, and then we'll hand things over to them. First of all, our first presenter today, and they're going to kind of co-present and go a little bit back and forth. So you'll be hearing them both simultaneously, if not jumping in on each other. We will see. But Juliana DePietro is currently the Overdose Prevention Program Manager and Interim Lead Program Manager for Central City Concern. She's a harm reduction advocate and practitioner with many years of work and volunteer experience in service to people who use drugs and people experiencing homelessness in Multnomah County, where we're based here and beyond. She's worked in direct service, housing, outreach, government, clinical contexts, all of which has helped inform her approach to overdose prevention and harm reduction work. She also holds a master's in public health. Joining Juliana this morning is Trevor Nissen. Trevor is currently the Associate Director of Recovery Programs in the Supportive Housing Department of Central City Concern. He has worked for many years in volunteer, community organizing, and direct service roles surrounding homelessness, addiction, and tenants' rights within Multnomah County. I can think of no two people who are better suited to give us something positive. So by all means, folks, let's give our attention to Juliana and Trevor. And thank you again for attending. My friends, take it away.
All right. Good morning, everyone, and thank you for that introduction, Paul. As Paul mentioned, we will be discussing overdose prevention in supportive housing at Central City Concern today.
Yes, good morning, everyone. Thank you for joining us.
So before we get started, we just wanted to share a bit of a content warning. I'm hoping that everybody who has joined this MedZed, who's listened to Paul's introduction, who's reflected on our title, has an understanding that today we'll be discussing overdoses, including overdose mortality. And I also just want to remind folks that it is really difficult these days to find anybody in our state, in our community, who's not personally or otherwise impacted by overdoses. So as much as you're familiar with what we're talking about today, please make sure to take care of yourself and also take care of your community. Recognize the impact of anything you share, even in the chat, as we don't know what experiences, fresh or otherwise, people are bringing to this space.
Additionally, we want to call out some terminology that we're going to try and use, and that in our programs doing this work, we attempt to use. The common terms that are listed here are not themselves, normatively bad. We don't mean to suggest that there is judgment over one or the other, but really mean to highlight that these terms do have connotations in different settings, and in kind of addressing the sort of culture piece that really undergirds the overdose prevention work that we're doing in supportive housing. The language that we use, the way we talk about our clients, the way we talk about overdoses can be hugely impactful in shaping the way our staff think, approach our clients, and ultimately begin to develop new tolerances and new skills for this incredibly challenging landscape that we find ourselves in. So just take a moment to, again, look over these. Through this presentation, you or Juliana and I may ourselves use the common terms that are there, which is okay. This is maybe even aspirational for us, as again, we try and shape the way we think about, talk about, and approach this work.
So before we dive into our content about overdose prevention at Central City Concern, just want to give a brief overview of CCC, our organization that Trevor and I both work for folks who may not be familiar. We are a large social services provider who attempts to provide holistic and wraparound care for people who are at extreme low income or experiencing homelessness, primarily in Multnomah County, but we also do some work in Clackamas County as well. This graphic is a little bit out of date. It's from 2022, so ideally the numbers on the screen are a little bit bigger. But as you can see, we have three major components of our work. First, we are a housing provider In 2022, we housed over 4,000 residents across our 30 properties. Both Trevor and I can speak to the fact that those properties and portfolio is growing pretty constantly. We're adding a couple properties early and later this year. And Trevor's going to dive in a lot more in detail about the different types of housing, permanent, transitional, and supportive housing modalities that we offer at CCC, but you can see just kind of an overview of all of the different types of housing that we offer. We are also a healthcare provider. As of 2022, we operated 13 federally qualified health center clinics, or FQHCs, with almost 10,000 health patients served across primary care and our behavioral health care services. We integrate those as best we can within our services because we understand that the folks who are walking through our doors or who are meeting in the community have really complex needs and that we need to treat a whole person. We also operate the largest withdrawal management program in the state at Hooper Detoxification Center, or Hooper Detox. We offer inpatient and outpatient recovery services for people who use drugs, as well as some acupuncture and naturopathic treatments. We're an early provider of those treatments for people withdrawing from substances back when CCC first started. And then, of course, our pharmacy program. And then finally, we offer employment services and job training to people who are coming out of homelessness, substance use that affects their ability to work. And so we offer employment services and job training through our Community Volunteer Corps program and our Employment Access Center, and really helping to support folks build confidence to be a part of the workforce. Many folks go on to work at Central City Concern, but also in the rest of the community as well.
So diving a little bit more into CCC supportive housing, defining some terms. So when we talk about supportive housing at CCC, a very sort of simple way to describe it is we're the people that are helping people in our buildings. We have a different department that is our housing department. That is the people who are overseeing the buildings, maintenance, facility, and turnover. But our department exists to really kind of wrap around individuals that are often sort of coming out of a period of either situational or transitional homelessness. There may be other sort of aspects of their care and needs, whether they be identity or sort of acuity based. But we exist in the buildings to typically provide case managed assistance for them as they stabilize, engage with services, clinical, peer-led, or et cetera, and ultimately transition to permanent and stable housing. So you see here we have the divide of transitional and permanent housing. Our permanent housing is what we may typically think of as the housing that we might access. There's a landlord, there's a lease, there's a building. There is no required engagement with staff aside from existing as a tenant. Our permanent housing may be an alcohol and drug-free community, which includes an addendum that is added to the lease, rendering it alcohol and drug-free. It gives our property management team the license to give people UAs, and clients are often, or residents selecting into these programs as a continued part of their recovery and stability. We have services that exist in permanent housing that are optional. We call them resident service coordinators. There may be case managers there that provide assistance to tenants as they're, again, kind of transitioning, maybe 1, 2, 3 years removed from a period of homelessness into kind of continued long-term self-sufficiency. It also exists to help smooth over any issues that might arise between a resident and our property manager, as well as doing some community building and resource finding. Our transitional housing programs, where people stay typically from 6 to 2 years as they gain stability and ultimately work towards permanent and stable housing, exists in a continuum of what we call low barrier stabilization housing. to maybe just proper transitional housing programs where people are staying from 6, sometimes even up to 2 years, usually with a program focus. The properties that I oversee are what we call recovery housing. Recovery housing is not necessarily housing first. Our programs have within their contracts and our program language a requirement that individuals have not only had a recent experience of homelessness but also a substance use disorder that they're looking to engage in sort of clinical treatment for. We provide peer services that will support them through the length of that treatment episode, which can be anywhere from 4 to 5 months. And after that, our peer case managers are assisting them, engaging with employment services, engaging with housing services, and throughout the entirety of their stay, helping them build a long-term program of recovery, connecting with the community, connecting with peers, connecting with services. Some of our other programs are what we call stabilization housing, or maybe treatment readiness. We're serving individuals who, as well, experiencing homelessness, have a substance use disorder, and may still be in a pattern or cycle of use that they are looking to engage with services for, but are maybe not yet ready. In those environments, there's typically a sort of longer bandwidth of tolerance and intervention for behavioral violations, including recurrence of use, much higher staffing ratios, and really doing a lot of skill building, a lot of acclimating just back into having a room of your own, services, etc. Let's see. Our recovery housing is also an alcohol and drug-free community, ADFC. What this means is their program stay can be interrupted by a number of recurrences of use, with the benchmark being 2. What this means is a client may have 1 recurrence of use that will lead to an intervention in which the peer case manager, who is working within the housing setting where we're often observing or verifying this recurrence of use, is intervening with the client, engaging with their care team, including clinical partners, employment partners, to wrap around that person and form a plan to keep them on the path of recovery. A second recurrence of use can typically result in an exit from our programs. However, our program supervisors have discretion to keep someone through an additional violation, usually dependent on what that person's sort of time in our program is looking like, their engagement with clinical partners, the circumstances surrounding their use, and other factors that, again, we may look at or just know from our continued work with that person. In kind of sort of diving into a little bit the work that Juliana and I have done with overdose prevention, say the recurrence of use sort of violations as they're informed by a lease or fair market housing laws, is a real big maybe kind of tension point that our work really centers around. Some of our programs may be leased, some may have amended leases where our violation and eviction process really needs to be consistent and informed by a fair housing or by a housing violation process, where we may have little ability to sort of deviate from that. But this is the setting that all of our clients are living in. The programs that we've piloted this in have anywhere from 50 to 100 individuals who are at various stages of early recovery, some coming immediately out of our Hooper detox, some that have 4 to 5 months, all neighbors sharing community with one another, engaging in groups with one another. So the management of use and behavioral violations in our buildings and on our floors. Again, it creates a point of tension for the work that we try and do with the individual, especially with individuals that we identify at a high risk of a fatal overdose. And changing the way that we work with that person, maybe against others, is a really big part of the work that Juliana and I have done. But I think maybe gone further than simply outlining supportive housing, and happy in the Q&As to elaborate a little bit more about any of the policies or things that differentiate one building or program for another, and how overdose prevention has to map into those different program and building modalities. But thank you, Juliana.
Thanks, Trevor. So after Trevor wonderfully outlined the context of supportive housing at Central City Concern, I'm going to zoom back out a little bit to talk about just briefly about overdose in Oregon and then within our organization's continuum over the past few years. For folks in Oregon, you're likely well aware, but we have been experiencing rising rates of fatal and non-fatal overdoses in our state in the past few years. It was really exacerbated by the COVID-19 pandemic. And you can see on these graphs really where the pandemic starts to reflect what I just said. On the right, this data is month-ending provisional counts of drug overdose deaths in the state of Oregon as a whole. You can see January 2019 here, January 2020, and then now here we are towards the end of January 2023 with really like a tripling almost of overdose deaths, if not more. On the left-hand side, you can see provisional data from Multnomah County. Again, this is a little bit out of date, so from 2022, but you can see the trend mapped pretty similarly here. We are, again, looking at pretty provisional data, but reports from 2023 and even early 2024 are suggesting that the trend continues to increase. The people who use drugs and people who use opioids, particularly fentanyl, are experiencing higher rates of fatal and non-fatal overdose than we were seeing prior to the pandemic. And at Central City Concern, that trend unfortunately was mirrored. We saw a significant increase in fatal and non-fatal overdoses in our continuums of care, so in our housing portfolio and in our clinic population as well. And we really started to observe that trend with urgency and significance in 2020, really starting to feel the, or 2021, excuse me, starting to feel the impact of those overdoses. So in a 6-month reporting period at that time, we had 23 overdoses reported via our incident reporting system. At least 3 of those were fatal, and I really want to point out that this is likely an undercount. Our incident reporting system relies on our staff to report incidents that happen within our continuum, and so the data that we gather is truly based on whether or not our staff observe an overdose, first and foremost, and then whether they correctly identify an incident that has occurred as an overdose and are able to report that as they share an incident report. So knowing what we know about overdoses in our community, we know that people who use drugs are likely to respond to overdoses, and those may happen behind doors outside of our purview, even within our 24/7 programming. So we're looking at some pretty startling numbers that we know are really likely an undercount. And we have limited data as well, countywide and within our system about whether those mortality counts are an undercount as well. We experience mortalities in our housing as we serve people with really complex medical and behavioral health concerns. And it can be difficult to identify sometimes what the cause of death was, particularly within the labs that we have at Multnomah County, taking about 6 months, last I heard, to identify the cause of death, particularly with respect to a drug tox screen, so seeing if the cause of death was an overdose. So that fatality count may also be an undercount. And then within an 18-month period, kind of spanning beyond those 6 months, we took a look at emergency department visits, and we noticed that 484 unduplicated CCC clients had ED visits following overdose events, which is really staggering for our community. And these and other data that we'll dive into really drove us to create a multifaceted overdose prevention program at Central City Concern. And I'll turn it over to you, Trevor.
Yeah, so diving a little bit into overdose as it's showing up in our supportive housing environments, you can see that the majority of overdoses that we're seeing in our community are with our staff responding, or are in our housing environments, representing 50%, with another 30% being in the community with our housing staff responding. So our housing staff, whether they be peer case managers, peer support specialists, front desk staff, on calls, are our front line in both response and awareness to overdose as it's happening in our buildings. With the remaining 20% happening around clinical settings or in other settings, typically maybe around downtown, where CCC staff is likely in transit between buildings. Many of us that work downtown, you'll see us if maybe we're wearing our badge or having our jacket. In explaining this data, we understand that our housing environments in supportive housing present an increased risk to individuals in providing isolated settings to individuals that are typically in early recovery, early engagement with treatment and clinical services, or themselves may be in a stabilization program where there's still a cycle of use that we are addressing in more of a harm reduction, housing first model. This is not to say that housing in itself represents a risk to individuals in recovery. We believe and know that our housing staff, the interventions and oversight that we're able to provide, are interrupting and preventing countless many more deaths. However, we recognize that we are only able to connect with individuals so much. Is the reason why there is such a strong emphasis on community, on open doors, on getting outside of our buildings, and not isolating, especially in a period of early recovery. Many of our practice or COVID-19 obviously is a compounding risk factor for individuals. Through 2022 and 2023, in a lot of ways, our programs were still rebounding from losses in connection as a result of COVID-19. It wasn't until late last year that we were able to bring offsite groups, Alano Club, 4D, etc., into our buildings to provide on-site and easily accessible meeting spaces. Our ability to do peer navigations with individuals was interrupted. And we know that isolation is just such a huge driver of particularly fatal overdoses. For our data as well, in thinking of the overrepresentation of housing settings, we also understand that these are the environments in which we're connecting with and seeing our folks the most. We understand ourselves really as the linchpin to a client's engagement with every other service that exists in CCC. We're operating the spaces that they call home. We're the place that they leave from in the morning to engage with community volunteer opportunities, with clinical services, whether they be treatment-oriented, primary care, with employment, and whatever they're facing out in the day, hardships, struggles, etc. These are the things that they're bringing home, and we really stress to our staff that it's imperative that we connect with that individual see how they're doing. In many of our programs, we have practices of checking in with someone in the morning before leaving the building, and organize, in some cases, daily 4 p.m. huddles, just so we can, again, bring everyone back, bring them together, and provide pro-recovery messaging. And then often our staff are ending their day attempting to connect with individuals that they did not see in the morning or at that 4 p.m., particularly if they're within their first 30 to 90 days of a program stay, which are the two sort of windows of time in which the majority of our clients are exiting. I believe our average length of stay is about 110 days at this moment. So with those individuals, we're really driving early and frequent engagement so that we can build community with them, interrupt the tendency to isolate, and reduce the risk that an individual have a recurrence of use that may result in a fatal overdose. It's Juliana.
Trevor, I think this is something that you know a good amount about, as you were a part of our community response as we built this project. So I will touch a little bit on some of the staff interviews that we did as we started to develop this project towards improving our emergency response, but would love to hear your perspective as well. So in preliminary data, as we were reviewing those overdoses that were reported, those 23 overdoses and more in our continuum, we found that in just about half of those cases, naloxone was administered, but that CCC staff only administered naloxone in about 15% of those cases. And while we know that people who use drugs, people in community, first responders are all well equipped to administer naloxone, such that, you know, just because we didn't do it doesn't mean it didn't happen. This 15% number really indicated to our team that we needed to improve our training for people who are in our staff teams who may be proximate to a potential overdose and who would need to respond. And Trevor, I'd love for you to dive in a little bit more on some of the content we saw within these staff interviews.
Yeah, thanks, Juliana. So first I'll say our housing and supportive housing staff are oftentimes drawn from individuals who are maybe themselves coming out of our programs. Typically, they have entered a permanent and stable housing environment that we may offer. And our Employment Access Center also offers manages on-call opportunities for people to staff our buildings. Beyond that, we put a heavy emphasis and preference for lived experience. We truly believe in the peer-delivered service model, and whenever possible, seek to have the people that are operating our buildings have shared experiences of those that we're serving. What that often means, though, is there was not robust training around how to respond to these situations, and in many cases, individuals were being, re-traumatized by the experience of serving an individual who, again, is walking a path that they were on maybe a year or two ago. So as an agency, we really recognize the need to socialize naloxone and the process for administering it immediately and normalize it to an extent that it wasn't. Prior to our overdose prevention initiative, naloxone had limited availability in our buildings. There was maybe 1 or 2 locations where it could be accessed, whereas now it is everywhere in our buildings, so much so that clients know where to access it. And this is a direct response to some of the things that you're seeing here, where they did not know what it was, they did not know where it was, and they did not know what it meant to administer it. And as an agency, really taking a hard look is what it meant to ask our staff to do already the hard work of serving individuals in early recovery in a changing drug landscape with a sort of stark and rising increase in fatal overdoses. What did it mean to keep those people within our programs as clients after this event, knowing that, you know, sometimes after administering naloxone, they may not want to engage with emergency services, or they may withdraw even further. Staff themselves, you know, needing time and support, you know, seeing an individual and needing to administer not only naloxone, but CPR. These are incredibly heavy events, and it is not a light ask to train individuals to be prepared to administer this. Hence the work that we dove into.
So in addition to some of the really immediate emergency response improvements that we identified as needed and that we'll talk about in more depth, but that Trevor hinted at that we've implemented at CCC, some of our preliminary investigation determined that we as an agency had a long way to go in improving care coordination for people at high risk of overdose. So within the folks who lived in our housing who had overdosed, almost 100% of them had a CCC patient chart of some kind. So they were within our health services, either engaged in primary care, in mental health care, in substance use disorder care, or some combination of all of it. They had, for lack of a better term, touched our health services at some point. And within those folks, 70% had a primary care provider at Central City Concern. However, only about a third, 36% of the primary care providers who served people at high risk of overdose were aware, either through documented notes or visits or any other way that we could determine that their patient had overdosed, their patient who was also a resident of our supportive housing programs. So when we look at those numbers, we're really seeing a gap between, even though folks being like really engaged in our care, having a doctor, having a chart, having the ability to go to our pharmacies, the connection with those PCPs for whatever reason, in really bridging and understanding and serving people at high risk of overdose needed significant improvement. And just want to acknowledge too, there's, even though that CCC provides full wraparound care, we also operate as a healthcare entity requiring patients and clients to sign releases of information in order to protect their patient privacy, such that if somebody overdoses in housing, our housing providers aren't necessarily going to call up the doctor and say, hey, your patient overdosed. And similarly, if somebody who's living in our housing reports to their doctor that they overdosed, the doctor's not going to call their supportive housing case manager. Without a signed release of information, without relationship building, all of these components that go into care coordination. And really acutely, when we did chart reviews, we saw several cases where primary care providers not only were not aware of overdose, but were working with people who were managing chronic pain or working with substance use disorders. So really actively working on parts of a patient's chart, factors of their life that can contribute to overdoses. And the primary care providers just lacked that awareness. Additionally, more on our behavioral health side, about a third of the folks with a CCC chart were actively engaged in substance use disorder services programs or in CCC mental health care or both. A lot of our early recovery programs have a requirement that residents will engage with substance use disorder outpatient treatment, either at CCC or somewhere else, depending on availability, depending on client comfort. And so we will serve residents who have comprehensive care from housing and health services all in one. Even so, a lot of those behavioral health providers at CCC were unaware of a participant's overdose. And I just want to acknowledge that it can be really difficult for people who experience overdose to share with any healthcare provider that has happened based on significant stigma. And there's also fear for folks who are in early recovery housing and in other parts of housing that they're going to lose their housing due to a recurrence of use. And so some of that sharing comes from really valid concerns from a patient perspective and a resident perspective, but also really indicates that we had room to grow in improving our care coordination. We recognize and understand at CCC that overdose risk can be heightened when particularly folks' mental health care, but of course also their substance use disorder care. So really their behavioral health care and their chronic pain management and other primary care factors aren't supportively managed. And while we provide 13 FQHCs and have a significant number of really incredible providers within our continuum, access to those services, those resources at CCC and otherwise tends to be limited, as you can see here when we were interviewing staff who were supporting our residents trying to access this care. They noted that health services is essential, but that the wait lists to get in are long. As such, we were seeing and still do see that withdrawal management was used as kind of a backdoor or a bridge. So if somebody had an overdose or a recurrence of use, they would get referred to Hooper and stay there, have their use managed there, maybe even get a bridge prescription for medication to support recovery. But even then, there would be a wait time to establish with a primary care provider who would then work on a more comprehensive care plan for them, including medication to support recovery. And then outside of CCC, but also within CCC, as I mentioned, really wraparound resources, employment resources, access to different types of volunteer opportunities, community building, all of the resources that our participants and our residents and our patients need to build up their lives and provide kind of those social buffers against overdose are just harder to access than they used to be. And just a note, we to the point about using Hooper as a backdoor resource, we saw that 55% of the people who were overdosed within our continuum of housing had gone through Hooper detox at least once in the past 18 months. And we know that overdose risk increases after people leave periods of sobriety, so including withdrawal management, including incarceration, including long periods of sobriety with recurrence of use. So that percentage is not surprising based on what we understand about overdose risk. But it is important for us to recognize the pathways that our participants, our residents, our patients follow on their journey so that we can improve that care coordination.
Mm-hmm. Oh, Juliana.
Yeah.
Before moving on, I also just want to call out that, these observations about the state of care coordination then and now, exist in a landscape where almost all aspects of our service profile are understaffed and overutilized. Many of the clients that are transitioning to supportive housing from Hooper or other referral pathways, we understand are screening at a higher level of care, often needing residential treatment beds that are unavailable, and instead being referred to our programs where they'll be receiving intensive outpatient treatment. So staff on all sides, clinical, supportive housing, are doing their best within a landscape that we know is suboptimal. And I know for my teams, we have really great and strong relationships with Hooper as both a referral source and intervention for individuals who are having a recurrence of use, and in the absence of other resources. We're often turning to Hooper and taxing that resource for individuals who, may be experiencing homelessness and in need of withdrawal management, or our clients may, benefit from a clinical intervention that exists in OTC or another partner, but is maybe just unavailable. This, I think, continues to be the landscape in which this work is happening. And the OPA's pilot has been, I think, really pivotal in kind of relieving some of the pressure from all staff working within a system that is not giving our clients everything that they need for no fault of any one person. This is just kind of what we're working with, and we get scrappy in getting the needs of our clients met, because we understand that if that recurrence of use, or if that moment in that client's life doesn't receive the appropriate intervention, it can result in a return to homelessness, where the work being done by all partners in their care team is typically taking a massive step back.
Thanks, Trevor. That's a super important point. So as we have hinted at, in response to these data, both from our incident reporting system, from the emergency department data that we reviewed, and then from subsequent staff interviews, our executive leadership team authorized and really encouraged the development of our overdose prevention project, which is now the program that I manage and that Trevor is also really significantly involved in supporting. And as we outlined a little bit, these data led us to prioritize housing with two specific bodies of work. First, really focusing on improving our emergency response. So we took a look at the issues and figured out the key areas that we could respond to with urgency and also create some urgent improvement. And then taking a deeper look into population pathways, so examining the people within our housing continuum at high risk of overdose and creating care coordination improvements. And I will go into the specific kind of 6 areas of focus of the project on these next slides. So first, as part of that emergency response improvement, we wanted to focus on naloxone access. And I think Trevor mentioned this earlier, but our goal from our project was to change the culture and change the access of who had access to naloxone, where it was stored, so that we could make direct access for our clients, not just our staff, and make sure that naloxone access in each building was really adequate for the level of emergency we were seeing. Additionally, we wanted to focus on overdose response training with the goal of having focus on our housing and supportive housing staff, who are uniquely positioned to observe and respond to overdoses, so that they had the tools and equipment to respond to those overdoses, but also ensure, to the points that Trevor brought up earlier, given who comprises those staff, that training is trauma informed and evidence-based and understands the context out of which our staff are coming. We also wanted to encourage conversations about overdose, about drug use in different ways than we had before. And so created a community education campaign that we'll dive into a little bit later. Additionally, we determined the need to pilot the distribution of some safer use supplies with a couple of populations within our housing programs. And I want to pause here and really emphasize that when I say safe use supplies at CCC, I am not talking about syringes, pipes, or foil. We don't distribute any of those items. Instead, we determined some supplies that are ancillary to supporting hygienic and safer drug use, and really using these as tools of engagement with people who may be in active use or who may be contemplating changes in their use patterns, to provide them supplies to not only use safely, but to have a conversation, a foot in the door about what their drug use is looking like, and how we can support them in reducing the harms around those use. And finally, we wanted to and have created an overdose prevention and aftercare, or OPA, program to pilot care coordination for residents who are at high risk of overdose across some of our housing and supportive housing sites that had really high prevalence of overdose in that period that we gathered data. And of course, that needed to procure funding and create some roles at CCC. So you'll see that as a focus area here. And that would not be possible without our partners at Care Oregon.
Yeah, and I'm going to touch on what has become, I think, the seventh kind of major point of work in this pilot, which is the cultural implications that overdose prevention has for our programs, specifically for those that are focused on recovery. So doing this work, we understand that individuals are approaching the work of recovery with a wide diversity of experience and perspective. As a department that is really built on peer-delivered services, we ask our staff to stand in their story, their lived experience of homelessness, addiction, and other kind of intersections of disempowerment as they're serving their clients, while at the same time existing within a professional direction that's defined by the agency. And there can be real tension between those two things. Some of our programs have operated on a one and done policy for recurrence of use. Others have existed and continue to exist on more of a harm reduction modality. All these different philosophies and approaches have produced countless stories of success and recovery. And we recognize that the current landscape of homelessness and addiction is changing in a way where we need to be more transparent and maybe I'll say have more of a harm reduction approach in the way that we're serving individuals that are coming into our programs, exiting withdrawal management, and seeking to get in recovery. The individuals at this moment are at a much higher risk for fatal overdose from even a single recurrence of use. So obviously a, say, one and done policy does not really serve us if we're trying to create an environment where clients feel safe in talking to us about the struggles that they're going through, in the returns to use that they may be experiencing that can precipitate and escalate a possible fatal overdose, and turning to us for access to the tools and interventions that we have to get ahead of those moments. So thinking about how we honor the experiences of recovery that some of our clients, or rather that some of our staff, have lived over decades. And the moment that we're in right now has been really essential to driving the success of this program, and has also allowed us to look at our approach a little bit more holistically and think about the ways that we can really meet our clients where they're at, which is the core value of our agency and our staff. And our clients are at a really difficult place, and it's really hard to meet them there. But we're committed to doing that work. I spoke a little bit to the intersection of different policies and approaches that inform this work. In my experience, the housing policies really provide kind of the framework in which all of our interventions live. Particularly the alcohol and drug-free community policies that define recurrences of use as a housing violation, that in some cases we have a limited ability to take a discretionary response to. So if we're thinking about, an individual who, this is a very common story, enters our program coming out of Hooper Detox, a 5 to 7 day stabilization, is still experiencing sort of extended withdrawal as they're attempting to stabilize within our program environment, and has a recurrence of use in, say, their first 2 to 3 weeks. This is something that we understand and have changed our programming around to support. And within a legal fair housing context, we again usually have to produce a violation for that person, a second of which can and will result in an exit from our programs. This is something that we are also attempting to drive change on, particularly within our leased settings, where the housing policies and violation process really take the lead on our interventions. But I call this out to say that the harm reduction and recovery approach themselves are not the only thing to consider when we're thinking of how we're supporting people within a housing environment. And these also inform some of the hesitation that our clinical partners who are not working in a housing setting may have in sharing information with us. Because a recurrence of use at OTRC SUDS is received and understood very differently than a recurrence of use within a housing environment. It is still going to, inform the work that all parties can and should be doing with that person, either clinically or on a peer level, but our ability to maybe safely be transparent with one another can be stymied by some of these policies. And as such, there's a lot of trust building across departments that needs to happen, is happening. I'm grateful to have Juliana and other partners on that side within CCC. But also a lot of kind of culture and perspective shifting for staff. My programs are typically operating with caseload ratios of about 25 to 32 people, all at various sort of stages in their sort of service timeline with us. Individuals that are new or have a recurrence of use take up a lot of our attention, and rightly so, as we seek to stabilize them. And as such, myself, Juliana, and others play a really important role in setting the what I like to call the kind of temperature for how we are approaching our work with this client. Some clients can be incredibly disruptive or at incredibly high risk for fatal overdose and need a higher level of care. This, I think, more than anything, drives my teams in their interventions and efforts to transition this person to resources that sometimes are unavailable. But it also drives that sense that that sense of overwhelm that I think really lives with our staff on a day-to-day basis within this changing drug and service landscape. And the more that we can lean in, create narratives around, a certain set of behavior being part of a story of success, and also outline some of the intensive clinical interventions that are going to be happening outside of our building that are going to drive behavior change within our building, can really go far in creating an environment where that client is going to be able to stay, get the support they need, where we're going to be able to engage with other people within the community that are affected by behavior, recurrence of use, or the behaviors that can sometimes surround that, towards our ultimate goal of keeping people within our buildings and interrupting fatal overdoses. So for anyone seeking to engage in this work or kind of understand maybe what is happening sort of on the housing setting, calling out fatal overdoses in a changing landscape is in itself a very powerful thing, and every one of my staff rally around that. And the work looks very different than it did a few years ago, and the stories of success, recovery, stabilization are changing. The interventions that are needed, particularly the social interventions that supportive housing staff are typically offering, clients may not be able to really receive or track those in their first 30 days in the way they were before. But those are the tools that we have in trying to affect someone in a non-clinical supportive housing setting. So really honoring the years and decades of recovery experience and work that our staff have as we're defining this new landscape has been crucial to building buy-in. And it's really made some of the success stories that we'll touch on later really that much more powerful as we're able to collectively look back and think about where we are now in our ability to serve clients that 2 years ago we were struggling with mightily.
Thanks so much, Trevor. So in addition to all of that really critical culture work that, as Trevor mentioned, is truly ongoing and takes time and takes humility and takes a depth of relationship and trust building, we've done a lot of work to improve our rapid access to adequate supplies of naloxone, particularly across our housing continuum. So at this point, all of our CCC managed housing buildings, which is over 30 buildings, have the overdose emergency kit wall mount box that you see in the photo on this slide, as well as the sign above it, so that folks really can see visually where each wall mounted box is. Each wall mount box has at least 4 boxes with 2 doses each of nasal naloxone. These were measured out so that they would be within 30 seconds walking distance from each unit, and I will acknowledge that that is walking distance, and so it does not account for every level of ability. And we make sure that there is at least 2, if not more, stations on each floor of every housing building. And this is a really significant change for Central City Concern, where, as Trevor mentioned earlier, we used to maybe have 1 box of naloxone, maybe at the front desk, such that staff didn't really know where it was and certainly did not know how to use it. It was really just there to provide for folks who did know how to use it. And so now not only do we have that naloxone, but we have also implemented agency-wide training. We are really seeing that the demand for naloxone, particularly with housing, is there. And I will dive in a bit more to our naloxone data in a bit. But at least within our housing buildings, we are distributing about 200 to 300 boxes go out the door. That doesn't directly correlate to the number of overdose emergencies within our buildings. We can't assume a one-to-one because sometimes folks will take the naloxone to distribute to people in active use in their community. Sometimes they'll take it for themselves. The boxes are unlocked and they are not monitored by staff except for refill. And that is truly to undergird the perspective that we know that our residents, the people who use drugs, people who are in community, in addition to our staff, respond to a significant number of overdoses, whether our staff or other first responders are there or not. So it's really critical that naloxone in our buildings is readily accessible, is not kept behind any type of locked box or any staff monitoring, so that participants, our residents, can get that naloxone whenever and for whatever reason they need it. I did mention also naloxone training. So one of our project areas was to develop trauma-informed and evidence-based naloxone administration and overdose response training, we have done so, and not only have we trained almost all of our housing and supportive housing staff, but we also have implemented that naloxone training into our new employee orientation so that everybody at Central City Concern as a new employee receives overdose prevention and naloxone administration at time of hire, or training at time of hire. We have a really incredible training team that is built on the training team that started within our housing and supportive housing staff. And I want to call out that those folks, we identified some leaders in that space and folks who are really excited within this housing and supportive housing communities to train their coworkers and their community on overdose response, many of whom had responded to overdoses themselves and so could speak to personal experience. They were the pilot launch of this training. They were responsible for training the rest of their cohort of supportive housing staff. And now we've built out the capacity for that training across our clinical teams, across our CCC staffing and our Clean Start programs, really ensuring that everybody at Central City Concern who needs to and wants to feel equipped to respond adequately to an overdose can do so. We've also made it really clear in our training how to respond, how to recognize an overdose. There's a lot of really understandable concern and fear, given the prevalence of overdoses, that anybody we see who doesn't seem responsive is overdosing. And we want to ensure that our staff can respond appropriately, but also aren't over responding. They are not giving naloxone to somebody who doesn't need it or giving too much naloxone. So we really emphasize in this training a focus on what an overdose looks like, how to confirm to the best of your ability that an overdose is occurring, and what to do, as well as what to do when somebody's clearly not overdosing.
Yeah, and I want to add maybe just that it's can't be understated. I think the gesture of that naloxone being available to clients without needing to go through staff to have access. It's not only in a way in which we've made sure that this resource is available to those who critically need it, but in my programs and in my department as a whole, it's been a really good kind of step in, again, changing the culture and conversations around naloxone, knowing that clients have easy access to it. Again, it is an admission that these things are happening. We need to talk about it. Let's destigmatize it. I've had some of my program supervisors recently express interest in organizing a training for clients within their first 30 days, which I see as a really huge win for this project, again, in kind of reshaping the relationship we have with clients in our buildings around overdose, but also around use more broadly, in creating kind of a culture of safe, transparent conversation about the reality of what our clients are experiencing now and what they may experience either themselves or through their neighbors while being in our buildings.
So in addition, all of this work recognizes and acknowledges that people across our continuum of care use drugs. Even within our alcohol and drug-free communities, people are using drugs, and rather than ignoring it, pretending it doesn't happen, hoping it doesn't happen if we don't talk about it, we've invested in a community care and education campaign on a couple of different fronts. First, we have printed materials, an example of which you can see on this slide. These are posters of various sizes that have bright colors, they're eye-catching, and they include some overdose prevention best practices, like don't use alone, start low and go slow, referring to how we encourage folks to use a small amount of a drug, maybe a new drug, and to use it slowly so they can really test the impact. And also encouraging folks to connect with staff if they're concerned about their overdose risk. We have an incredible person, Lisa Greenfield, who volunteered her face to be on these posters, and just really presenting that we are a safe space for people to come to, which can be complex when there are lease considerations involved, and we want to make sure first and foremost that people understand we care about their livelihood. The printed materials also include lanyards and t-shirts for staff to wear that say naloxone saved lives, ask me how, again, to encourage folks to ask questions about naloxone, what it is and what our involvement in supporting our community in preventing overdose looks like. We also printed out onto some lighters to distribute to our participants with the Never Use Alone hotline, which is also on the poster. And that hotline is a really key resource if our participants lack community that they feel safe calling, if they're going to use, or if they don't have a community to use safely with. We know that, as we mentioned earlier, isolation increases fatal overdose risk. And so even if somebody is in their room using, they're not allowed to have a guest or they don't choose to have a guest, they can call a hotline and say, hey, I'm about to use, can you make sure that if I stop responding, somebody comes and checks on me? And then, as I mentioned earlier, we provide some ancillary supplies to support safer use. Those supplies include alcohol wipes, bandages, sterile water, sterile cotton. It really depends on the method of administration that someone identifies. Those supplies do not include syringes, pipes, or foil. But again, materials that support somebody's safest possible use, as well as conversation, engagement, and education about why those materials are in the package. We know that when people use drugs, especially in periods of really chaotic use and without access to other resources, just because they don't have access to sterile supplies doesn't mean they're not going to use. It just means that their risk of getting infections through the use of shared syringes or shared pipes just increases. And so from a public health perspective, it is evidence-based for us to provide some of those supplies, as well as those conversations about why those supplies are there. This entire campaign, I can't say it enough, is really focused on encouraging our staff community and our participants to have open, non-judgmental, and caring conversations about the fact that drug use exists and about what overdose risk looks like. And then our OPA model, our overdose prevention and aftercare team. So this model was developed based on a few different transitional care models within our community. So for folks who are familiar with OHSU's New Directions and C-Trade teams, we really took a look at really successful programs that do outreach to folks who are vulnerable and who have several co-occurring complex conditions that put them at high risk for significant health consequences. We also took a look at post-overdose response teams or PORT programs across the country for some of the best practices that they implement. And those include a rapid response to people who overdose. So within 24 to 72 hours, checking in with somebody saying, hey, I heard you overdosed. How are you? What can I do for you? Really building rapport and building trust with that person. So an outreach model, a person-centered model, and focusing on building relationship, trust, and rapport with somebody really early, and as often as they are willing to have us be there. We also operate with a harm reduction orientation. So our overdose prevention and aftercare model doesn't require sobriety as an outcome for people within our care. Instead, we focus on what that person's goals are. And maybe that person's goals are including sobriety, especially if they're in our early recovery housing and they're struggling with recurrence to use. And we certainly support that as well. And some of our folks may never want to stop using drugs, but have goals of getting into other behavioral health care or maintaining their permanent housing or getting employment. And those are all goals that we want to support our participants in doing and helping them recognize and understand their overdose risk and how to manage it. We are piloting this program at 5 of our housing buildings, one of which is an alcohol and drug-free early recovery program that we absolutely love. We love all of our programs, and this one has had some of the most important reveals of that tension that Trevor talked about with the culture, and it's just so much rich opportunity for us to continue to grow together and learn from each other. We have a stabilization housing program that we work with as well, and then 3 permanent supportive housing programs that are not alcohol and drug free. At all of these sites, the supportive housing staff have been trained in understanding a bit more about how to recognize when somebody may be at high risk for overdose in their community, including when somebody has overdosed recently, either reported or observed, or maybe there are changes in their behavioral health presentation. Maybe they've had a period of incarceration, maybe they've just experienced a loss, some of the things that can drive folks to use in different ways and increase their overdose risk. So we've had conversations with folks at those housing buildings and said, this is a resource for you. If you're worried about somebody, refer them to OPA. Our OPA team is comprised of 2 clinicians, one nurse and 1 qualified mental health associate, or QMHP. And those folks will review the referral, and then if the referral is appropriate, which almost all of them are, our criteria are extremely low barrier, our clinicians will make contact with the supportive housing staff and then also attempt to contact the client within at least 48 hours, if not sooner, of the referral. Once we make contact with the participant, let them know who we are. We provide tangible harm reduction interventions, including either connection to the supplies that they need or providing some of those ancillary supplies that we offer, conversations about what their use looks like, and really focusing on a person-centered assessment with targeted care coordination goals that the client establishes.
Yeah, and I think to add to the work that's done with the OPAs, in the stabilization and ADFC supportive housing programs, with these having sort of a program modality layered over a client's residency, we've also stood up a weekly huddle between the OPAs and the supportive housing team to ensure that there is that coordination around the interventions that both sides are leading, and to also do some level setting around the behaviors that we're seeing in a housing environment that, all things being equal, could drive an individual to a discharge into homelessness or another environment. And having the insight that we get from the OPAs teams has been really critical in driving our own interventions. Again, understanding behavior that we are not always trained or have capacity to understand and support, again, as we're receiving clients that have a higher level of acuity of substance use disorder and behavioral health, often co-occurring, and being able to really kind of reshape the stories that we're telling about this client, understand what's driving behavior, understand what's driving their use is really central in the work that my staff in supportive housing doing. So that's been, I think, one of our biggest takeaways, to the aforementioned call out around care coordination, is the more that we can create kind of informative environments where people are creating a shared narrative of care around the client, the more likely that we're all able to achieve the success that we're seeking to have in our own different programs. There's not always alignment between what we're trying to do, or at least our approaches, but intentionally shaping and creating that alignment through those huddles is critical.
So now going into some initial data, our naloxone distribution and our training program have both been in operation for over a full calendar year now. And so I'm really delighted to present this graph of where our naloxone distribution has been for calendar year 2023. As you can see, our behavioral health service line, so our outreach teams in behavioral health, our Hooper Detox Center, some of our outpatient programs and others did distribute kind of the most volume of naloxone, but our housing programs are right there too, which I think prior to initiating this project, prior to really diving in, we may not have anticipated, but we're really I'm just so pleased to be able to meet the significant demand that is in our housing continuum of care. When you see our health services programs on here, that's referring to our recuperative care program and our Hep C elimination team, both of whom either have naloxone on hand with respect to our CP program, or who distribute naloxone as they're screening folks for Hep C and HIV with respect to our HIV program. Our social enterprises team, our Clean Start program, and our CVC team also distribute a significant amount of naloxone and administer a significant amount of naloxone. They are also part of our front lines, and they're out in the streets. Our Clean Start folks are pushing the trash barrels around town. You'll see our trucks driving around picking up trash from encampments, and those folks encounter a lot of overdoses as well. So they will use and distribute naloxone to people in need. And then the numbers for our administration really refers to the sites that don't directly serve or distribute to participants, but that keep naloxone on hand in case of emergency. And all told, in calendar year 2023, Central City Concern distributed almost 8,000 boxes, or almost 16,000 doses of naloxone to people who use drugs, either in emergency circumstances or otherwise. And it's incredible, the work that we've been able to do. I'm really proud of CCC, and I'm really proud of our residents and our participants for the amount of work that we do in ensuring, as well as a part of the rest of our community, the saturation of naloxone across our portfolio. Additionally, I know we showed this early on, or some of these data early on, and talked about the percentage of times within reported incidents where our staff were using naloxone to respond. And you can see in 2022, about a quarter of the incidents where known or suspected overdose occurred, we were not seeing our staff use naloxone. That number has shrunk, and so now almost half of the incidents, our staff are using naloxone to respond to overdoses. As you can see here, there is a chunk that says not reported. Sometimes the incident reports that we get are just about somebody coming to the door of our housing building and saying, hey, there's an overdose happening outside, we need naloxone. These data are really important for us to gather too, so that we can encourage as complete of reporting as possible. And sometimes we're just not going to have all of the information. I also just want to recognize that in these no percentages, there are a portion, unfortunately, where our staff have encountered a resident or a participant or a community member who has already passed away from a suspected overdose, such that naloxone administration would not be indicated. And we are continuing to monitor the reports that we get and see what opportunities we have for improving our own training, for improving our reporting, and improving our overdose surveillance within our continuum. And then I want to talk a bit about our mortality outcomes. And so we've seen a significant increase in reported overdoses between 2022 and 2023. In 2022, there were 46 overdoses reported across our continuum, and that came from incidents reported in our housing, but also when our primary care providers and others would be notified by hospitals that somebody had overdosed and were returning to care, or who had passed away. In 2023, we had 176 reported overdoses, so 130 additional overdoses between the 2 years. And we're seeing this increase perhaps for a few reasons. One, it's likely that there's just an increase in overdoses in our community just based on what's going on in the drug supply and ongoing factors that lead to overdose. It's also possible that with the implementation of this campaign, we're increasing our employees' ability to understand what is an overdose, so that reporting is becoming more refined, and as such, we're seeing a higher proportion of incidents reported overall that reflect an overdose versus just a general emergency. And then I also want to acknowledge that we're seeing an increase in requests for naloxone that may increase the number of reports that we receive, because now people know that there's naloxone in CCC housing buildings, and we have, especially in our downtown Old Town core, but really across our portfolio, we have community members running to our doors, knocking on the doors, our staff come out and respond. And so we may be involved in more overdoses than we previously were because we are a large provider of naloxone. Even though this is a significant increase, it is likely still an undercount just based on the factors that I outlined before, knowing that so many of our residents and our patients are responding to overdoses in their community and not reporting it to staff, so that we may have overdoses that we likely don't know about. And we continue to build trust with our participants and our residents so that we have a better understanding of what those overdoses are looking like and how we can best support our folks. But I'm really heartened to see, even with all of the data disclaimers that I provided, that we have reduced the percentage of overdoses that lead to mortality from 18% in 2022 to 6% in 2023. Some additional successes I want to reflect on for our overdose prevention and aftercare program. We've got a couple that are focused on care coordination. Trevor, do you want to talk about the one with the FORA partnership?
Yeah, so this was an individual who had 2 recurrences of use and was demonstrating some behavior that was destabilizing the floor a little bit. OPAs in their work, or our OPAs in their work with this client had put in referrals to for an attempt to get them connected with residential through their program stay. This, of course, takes time. However, having the groundwork for that already laid and a partner being able to focus on doing that and advocating for the client really created a sense of, I think, a safety and assurance amongst my team that we would continue to hold that tension that for that client in our program as we were waiting for that date to come to get them into FORA withdrawal management. They ultimately did. The OPA's team does not stop working with individuals when they're exited from our program, so they were able to continue supporting this client as they navigated withdrawal management and get connected to a higher level of care that our staff attempts to do on the regular and either bumps into issues or maybe simply doesn't have capacity. Again, we are working with caseload ratios far outside the county defined best practices. So having another team to not only advocate but focus on that work was hugely influential in kind of bringing down the temperature around that client, get some commitment around how we can kind of hold space, hold tension, and then get them where they needed to be. We had another such instance just this month where an individual had their second recurrence of use following the death of someone very close to them. Our OPA's referral calls out experiencing death as something that could precipitate a possible fatal overdose. And so we were able to use the pilot as a reflection point in understanding this client's use against some spotty engagement with services, which is something we might look to and saying, hey, how is this client doing? Are they showing up? Are they engaging? What's the effort level? Are we not seeing them? They're not checking in with any clinical partners, et cetera. Through that reflection, we committed to keeping that client, continue to work with them. 3 weeks later, we were able to get them into a sober living house in Washington County, where their brother also lives. That reconnection with family, another thing that our team facilitated, and ultimately interrupt a possible transition back into homelessness and keep them in line with their recovery path. So huge successes from having OPAs as a framework through which we can understand our work with some of our highest risk clients.
Absolutely. share another really wonderful success story about OPA participant in one of our permanent non-alcohol and drug-free communities. So not a space where recurrence of use will lead to lease ending and termination. So this person had pretty significant co-occurring psychiatric concerns in addition to their overdose risk just based on fentanyl use. And our OPA who connected with them noted that this person was really wary about walking down and going to a clinic, and they, as such, had developed enough trust with their mental health provider to receive an injection for their psychiatric concern, but really didn't want to go back to the doctor with any regular cadence. The ability for the OPA to go to the person's unit to meet them where they felt the most comfortable helped the resident to trust them and trust their perspective, and then also really start the conversation around medications to support their recovery, to support their safe management of their opioid use. And I'm really happy to report that that participant was excited to receive their first ever Sublocade injection. And just thinking about OPA from a harm reduction perspective too. And so we had a participant in one of our transitional ADFC programs who really wasn't interested in working with OPA at all. This is a person who smoked their drugs as their method of administration and really thought that harm reduction and whatever care was just for people who inject drugs. But our OPA was able to build relationship and rapport, and also share some practices for safer smoking. And knowing that smoking is a safer route of administration than is injection, and then also the ways to keep that smoking safer. That helped that participant not only understand that the OPA program really cared about their livelihood and their well-being, but also helped them understand their risk reduction for their HCV or HIV transmission, even while they were smoking and not injecting. And then finally, I want to share one of our program's most favorite quotes, which I apologize in advance, has a couple F-bombs. Our program is a short-term period of care. And so we really want to focus on connecting folks to more ongoing resources in the community. And we work with our participants for 90 days or until they tell us they don't want us to work with them if that happens before. So we worked with a participant who lives in one of our permanent housing buildings. It's non-ADFC. And we worked with this person for the full 90 days and approached them to discuss kind of program graduation, where they were at, how the program had supported them, what they were working towards ongoing, what care connection resources they had. And this person and I'm just going to read this, said, "The first day I met you," talking to their OPA, "I almost said F you and F this. I've been shooting dope since you, the OPA, were in elementary school. But through this program, I learned that you can still be an addict and do different things and be safer and get to a place where you can be more a part of society." So this person reflecting on the fact that even though they don't have a goal of ceasing their use necessarily at any time, they can use more safely, more functionally, maintain their housing, participate in community. And that was really through their collaborative work with the OPA program. So some challenges and opportunities overall, we've touched on a lot of this, but just in reflection, I think some of the points that you've made, Trevor, about the tensions between providing a harm reduction based clinical team and the really important perspective from our early recovery program can sometimes be in tension, though they are all perspectives along the continuum of care for people who use drugs. We also hold tension as an organization, being both a person's landlord and sometimes also their health provider. And so while we're all CCC, especially with landlord-tenant law and the leases and program contracts that we operate, sometimes the outcomes for our participant can be complex just based on those dual roles. Ongoing, we know that the war on drugs continues. The rhetoric around drug use in our community is incredibly negative, and that increases stigma for the people who use and then fear of reporting. And to that, we continue to have reporting and surveillance challenges to truly understand the full spectrum of what overdose looks like at CCC. But we're using all of these as opportunities to continue to improve our services, to continue to learn from our resident population and to learn from our staff. Trevor, is there anything you wanted to add on this one?
Yeah, and thinking of framing these challenges maybe for our larger audience, the dual role that we have is not one that we necessarily have with all clients. And so I think each of our departments feel this themselves, and that they're only one aspect of a person's care. And if they're in CCC housing, to Juliana's point, there's that understanding that, hey, we're all CCC, our ability to interface is that much easier. But for clients that choose to receive housing outside of CCC or get clinical care outside of CCC, the challenges around coordination, transparency, and the like heighten. And our ability to form, or rather our work to form partnerships with non-CCC entities has been hugely critical for clients that we don't have the benefit of kind of being a large part of their care team. And especially as housing providers, understand that there's maybe limited ability to disclose or interface with clients, as well as for them to maybe want to participate in that dialogue or have their care providers have that dialogue outside of the client or sort of with them. And that can sometimes be, again, a huge barrier, but ultimately, we value self-determination and client choice, and really just do our best to try and present options and resources to clients in the most safe, accessible way, which can be challenging in the service environment that we're in.
So some recommendations that we're hoping everybody takes forward. For any provider of housing, supportive housing, for any clinical provider, anybody on this call, especially if you work in the downtown, Old Town area of Portland, but really anybody across the state of Oregon or beyond whose community is impacted by overdose, we really recommend that all employees who may encounter overdose are trained in trauma-informed and evidence-based naloxone administration and overdose prevention response, at least once, if not regularly, as we know that the drug landscape is changing and our best practices will shift to respond in order to support people who overdose with as least harm and as most life-saving potential as possible. For supportive housing providers, we've really seen the need for having naloxone readily available and accessible to everybody in supportive housing, staff and participants alike. For providers who aren't embedded in housing, so for our clinical providers, really encouraging the points in time when you can have non-judgmental and non-stigmatizing conversations with your patients about their overdose risk. Really understand that the overdose risk portfolio is broader than just using fentanyl, using opioids, but includes some of the pieces that we've talked about today. So experiencing a loss, having a change in other behavioral health concerns, using a new drug, using with different people, using drugs from a different supplier, a period of recent sobriety, including withdrawal management or incarceration. These are all pieces and moments, if you learn in your patient's history or their recent history, that it might be a good time to check in about their overdose risk. And then any interventions offered, so thinking about medication to support recovery or other clinical interventions, think about the context, especially if somebody is living in a supportive housing environment. Think about some of the complexity that Trevor and I have reflected on today, such that some of the interventions offered may be in conflict with or not possible for the person to follow through on. We know, especially for people experiencing homelessness, that maintaining their medication, keeping that safe and locked is almost impossible if they're out in the community. And so thinking similarly to some of the complexities with respect to supportive housing. And then finally, as you provide training for employees who may encounter overdose, who may respond to an overdose, recognize, especially with your staff team of peers, of people who really bring their lived experience to the fore in their work, make sure that there are adequate resources for debriefing and processing that overdose response. Responding to an overdose doesn't have to be a significant trauma, but it often is, especially for people with personal experience, if they've overdosed themselves, if they've experienced overdose during their drug use, experienced overdose of a loved one. And so recognize that the ability to continue to show up to this already really difficult work can be impacted by emergency first response on the job. And so ensure not just that a supervisor checks in, but perhaps have a team of trained debriefing facilitators. We do at CCC, and we'd be happy to share resources, but make a concentrated effort to ensure staff wellness going forward. Some resources needed. We don't have a blueprint for everybody because your context is going to change. But just some overall things to consider as you think about implementing any component of this project. Trevor mentioned earlier, our behavioral health and our housing resource landscape is really understaffed. And these projects will require either additional duties or additional people. And so make sure as you're doing an evaluation of your readiness to implement a project like this, that you have the staff either already existing and who can have additional duties, or that you have capacity to hire folks who can provide overdose response training at a regular cadence, who can order and restock and inventory the naloxone, making sure that there's somebody who can get it to each building and to make sure that it's not expired, and to the way that we do this at CCC is that it's folded in to our community building assistant duties, so that folks who are already checking the building for garbage and who are doing maintenance work are taking a look at those cabinets and seeing where the naloxone is and restocking and requesting. And then, of course, resources for debrief support. We are lucky enough to have a cohort of leaders who are trained in debriefing, but we recognize that the ability to hold space for debriefing takes a lot of time and emotional labor on behalf of the leaders and on behalf of the staff who are sharing. And so just recognize the people resources that go into providing that support. And then, of course, our best friend, naloxone. That's absolutely needed, especially if you're thinking about scaling it up within a housing portfolio context. And for naloxone outside of a pharmacy, it is available for direct purchase over the counter. You don't need a prescription anymore, but you will need a budget. Emergent Biosolutions that makes Narcan, one of the most common versions of nasal naloxone, that costs about $43 a box. So it's expensive. There are no cost resources for providers through the state of Oregon's clearinghouse, which is an incredible partner and resource, but is limited. Their scope of providing no-cost non-pharmacy naloxone spans not only nonprofit providers like us, but also other first responders, law enforcement, and schools. So note that state resources may be limited, and if you have any advocacy capacity, please advocate for more clearinghouse resources for the state. To that end, just keep in mind that with the legislative session right now, it's unclear what the naloxone funding landscape is going to look like in the next calendar year. So again, those state resources are uncertain. And then from a people resource perspective, we recognize that all of these implemented programs may be really destabilized by employee turnover and the inability to hire based on the resource landscape. So additionally, from an advocacy perspective, advocating for higher wages and all of the things we know that can really improve retention in a behavioral health and housing resource landscape. And now we're ready for some Q&A.
Wow, that was fantastic, you two. We are so grateful to be able to have you here today. This is absolutely wonderful. And it is very interesting. It's like about midway through our presentation this morning, attendee numbers started climbing midway through, which is like, that's odd. That doesn't usually happen. And when that happens, it's an indication that folks who are in the session are like emailing their friends and saying, you need to get in here and check this out because this is really awesome. And you could see the attendees growing after the start in the middle of that, because I think it's just a testament to how engaging this was for folks. But just really appreciate all of this information. It is great. And a word to all of our friends who are attendees here and who are still with us. I just want to let you know we're still going, and we have an opportunity to take advantage of Juliana and Trevor being with us today. And you can ask any questions that you may have. And this is a great opportunity to find out other things that they can provide insight on. As a reminder for everybody, I don't know how many people have been frantically taking notes today, but you're going to be getting copies of these slides as well at the end of the session, so you can refer to those. Bravely, Trevor and Juliana have made their email addresses available as well. So it's like they're going to, I think, be busy afterwards, because sometimes people want to be able to ask questions more privately. But I wanted to just get things started by asking the two of you a couple questions, if that sounds good. You had both mentioned the perception of overdose and use of drugs in the media lately. Within the environment of the Portland area, regardless of our other more rural environments, but what you see happening in the state of Oregon, do you think the media is getting it and improving the way they cover this? What's your take on how the media is responding to things and handling? Are they even covering your work?
I will say there have been several recent opportunities that our CEO, Dr. Andy Mendenhall, has had to speak to the media, to the press, and directly to Portland and the city or the state proper. And I think in that way, we have been given opportunities to tell our story and the amazing work that's happening. I think, as with most things, there is a bias towards negativity. Oregon as a state is a leader in addiction and mental health need, but is unfortunately not a driver in resources for those things. So in one way, I think there is an appropriate focus on those aspects of the story that resonate pretty deeply with my staff and even my own experience of trying to serve clients in this moment of time. However, I do think that the story of continued success, of recovery in innovative approaches is often lost. And I think we could all sort of stand to see a little bit more of that within the media. Central City Concern, and our partners every day show up to serve people in our buildings, in the streets, and in the community. And while there's, again, an overwhelming need, I think our sort of larger continuum of service providers know how to do this work and do it very well, even in a landscape of scarcity and need. And I think there could be more uplifting of that, which, if there was, could change the temperament of maybe not only our community, but also our staff as well, right? Because I think that as we all go home from our jobs and kind of absorb or confront that, it can, and I think does, maybe shape the way shape our relationship with the work, right? And the overwhelm and the stress and the trauma that we're all holding.
Thank you. I know it's a crazy universe because we are in the knee deep into an election year coming up. Are there things you're hoping that will improve in terms of relationships with city government? Have you found that they've been amenable and easy to work with in some ways? Or I'd love to hear your take on how things have gone in terms of building what you've been building in terms of like relationships with the city and what perhaps could be different in terms of or are there concerns that you have looking forward?
I think we really value our partnerships with all of our local government and our state government. And we all have different roles to play. We all have lanes, right? I know I'll just use the example of the opioid settlement dollars that are coming through the state and how different jurisdictions are intending to use them. Our city of Portland is really focused, and rightly so, on public safety and the impact of public drug use on community safety. Our county providers have a robust health department that has a harm reduction branch, and so they have been providing naloxone and other supplies to people who use drugs for decades now. And so as we think about the different lanes that our local government plays, we continue to have the opportunity as a really large provider to maintain strong partnerships with those local government agencies and be at the table for some of the important conversations about community response. And just from a personal community perspective, I know there are a lot of providers in our community who aren't as big as CCC and who do really critical work and see a lot on the ground that perhaps we don't see with the suite of services provided. So my hope for our local and state government is that the opportunity to engage a wide spectrum of service providers and also a spectrum of perspectives of people who are in active use or people who are in recovery in really driving where we go from here. That would be my dream, especially with perhaps the opportunity we have now in the Portland metro area with the declaration of an emergency around the fentanyl crisis. I hope that drives just a wider community conversation.
There's a lot of energy around what is needed and what would be new for our city and our state. However, I hope the resourcing of the existing is also focused in these next legislative sessions. I trust that I share the experience of calling out staffing or resource needs with the county. And these maybe aren't always or seemingly given the same maybe priority as new emerging programs that again fill a need, but again, thinking within the context of that narrative that our services are broken, we don't, have enough, what we need is new. I think many of us within our respective lanes know what we do really well and also know what we need to continue doing it better. And that's something that I hope remains kind of part of the discourse and something that I've experienced as getting maybe a different sort of attention in this current environment we're in.
Great, thank you. I am getting some questions coming in from the audience here, so I want to go ahead and I mentioned that we had some folks join midway, and this person asks, they say you may have already addressed this before they logged in, but they wanted to it's good to reiterate, right? What is the point of entry for someone with an addiction to get into your housing program?
So again, I want to say within supportive housing, we have a wide spectrum of programs. Some are pretty partner specific. I think of our programs that are funded in partnership with the Department of Criminal Justice or the Portland Police Bureau that have generally a re-entry or criminality focus. Some that are identity specific, such as the Caribou or Flip the Script programs. But generally and broadly, an individual that is experiencing not only addiction, but I'm going to say homelessness as well. Hooper is a main driver of access into our programs. Other withdrawal management services, again, such as FORA, also refer into our programs. Individuals will self-present as well to our buildings to express their interest and maybe connect us with their care team that's working with them. If you're a care provider working with someone who is experiencing addiction and homelessness, I would encourage you in this moment to take down my email, and I can do my best to kind of steer traffic. Most of our programs, and specifically the ones that I oversee, where the main criteria is homelessness and substance use disorder, we have an open wait list that we work through. We are always willing and wanting to create partnerships with people. And yeah, for an individual who is maybe just looking for housing and maybe not experiencing homelessness or and a housing precarity in that moment, we also have a housing office, which is on 5th and Everett, that individuals can present at. We have, many wait lists for our, what we call our fair market sort of permanent housing settings that an individual can sign up on. In this moment, what I hear from our housing partners is that we're working through wait lists in anywhere from 2 to 3 months. Not all of our buildings are ADFC, but if an individual is seeking that kind of environment, that can also be an avenue for them. And maybe I'll say lastly, engaging with intensive outpatient treatment, either with CCC or non-CCC. This is another area where we are often receiving referrals of clients who it's identified that stable housing is a barrier to their continued engagement with treatment. So again, in broad strokes, Hooper is a big one. Presenting at our buildings, sending a referral to our programs, which I can provide to anyone that's interested. Again, feel free to reach out to me. And also going to our housing office, which is on 5th and Everett. It's a really difficult landscape. So I think that's a great and amazing question. And I'll say in maybe beyond what I've said, forming partnerships with people in housing is, I would say, really critical to helping people as well. There's an overwhelming need, and whenever there's opportunity for my teams to do tours, exchange cards, etc., can go a really long way in not only helping people access housing, but also kind of building that relationship of coordinated care that's going to be needed for that person to successfully remain in housing and then transition into long-term permanent stable housing.
One of our regular attendees had put this comment in here, not so much of a question, but they've appreciated how the term OPA has evolved into almost like a personal noun, right? Just like, like an affectionate term for a grandparent, just my nana or my oma, right? Just that kind of, personal connection there with the role is, I think that's pretty amazing. I think that's pretty lovely when you think about it. This question, someone was curious about the specifics on how staff trainings have been shifted to helping build resiliency, acknowledging compound trauma, inadvertent biases, and just how, amazing and challenging the work can be. They have been asking their company to better support frontline staff, and here you've already been identified the need and taken action. Big question, but just curious what that inspires.
Yeah, an amazing question, Molly. So as an agency, we have a suite of trainings that we provide both in person and virtual to all new clients, or rather, sorry, all new staff, that will cover, again, the fundamentals of, professionalism, fair market law, but also touch on, trauma-informed care, motivational interviewing, strength-based approaches, emphasizing self-care, emphasizing, things such as equity, intersectionality, and the like. But I would say more than, providing trainings to staff, typically in the beginning of employment, I think where the support is really felt and lives is in the way as leaders we structure the day-to-day work of our staff, create opportunities for us to intentionally check in with one another on, what is our current and evolving experience and relationship to our work, creating intentional environments to check in with one another across teams when possible, but also within the teams. Those are the spaces where, say, myself or the supervisors that I oversee are strongly encouraged to, think about the way we're talking about and coordinating our work, and see the opportunities to shape, influence, support kind of our perspectives, right? Raise up those trainings that all of us may have been in at one point, usually early in our employment, but really confront the ways that like the work and the way it's structured may be far away or close to the spirits of those trainings. So in short, it's, I would also ask your organization and leaders to think about the way your work is organized. Something that Julia and I both touched on as super important is the need to debrief. I think that is such a huge part of resiliency, and also, ensuring that we're having healthy relationships with the traumatic work that we're doing, and that the lessons that we're all learning and taking away are in line with the mission and spirit of our training organization, et cetera. Because if you're leaving that processing to be done ad hoc or whenever there's an opportunity for that person to do so, if ever, right? Sometimes, like some of our staff and ourselves, we never have the opportunity to slow down, or it doesn't feel that way. So when the next sort of moment shows up, everything just compounds. So that's, there's the training itself, and then there's also the intentional organization of the work, and a big focus on debriefing and an emphasis of on our supervisors to slow down when possible, and show your staff that you can slow down to talk about the things that we're doing.
I think I'll just add that a lot of what I focus on as a leader, and I think a lot of what our trainings have shifted to focus on is validation and acknowledgement, that people who show up to work for our agency, especially if they are coming directly out of our services or other services, if they've experienced homelessness, chaotic substance use themselves, will be impacted in different ways in receiving information in training than others. And I've received a lot of strong feedback from folks who say thank you for just acknowledging that, and for just kind of gently nudging me to remember my experience and how I exist and how I show up. I think another really key piece for all of us as we provide training and support to our staff teams is recognizing that the work that we do is always going to be bigger than us, and it's always going to be bigger than even us as CCC, as a large organization. There, as Trevor mentioned, Oregon is a leader, unfortunately, in really like a huge disparity between need and available resources. And so really reminding our staff teams that yes, the work that you do is really difficult. Yes, it's going to be extra impactful and difficult if you're showing up, or if we're asking you to show up with your lived experience as a peer or otherwise. And we are not charging you with solving homelessness. We are not charging you with solving substance use. And therefore, we need you to stay safe and healthy and resilient in this work. And so, really tapping into the system-wide need, and that the work will always be there, and that folks need to take care of themselves, but also engage in community support that includes their employer, right? There's a lot of, I really don't, this might be a hot take, but I really don't like the term self-care, because it puts the onus of care directly back on an individual who may be caring for a whole bunch of other people, their children, their families, et cetera. And so ensuring that our staff teams have not only good personal practices that can keep them healthy and safe, but also that they have a robust community support network that they can tap into that can include their employer so that they can stay healthy and well in this work.
Wow, I like your take on self-care, Juliana, because it's true, right? It sort of puts everyone, oh, you can handle it, take care of it yourself, and not everybody's got that ability or that strength or that resource to summon. Sometimes you're just all out of spoons, and you just can't do it. We talked briefly about that fentanyl state of emergency task force. Does Central City have a representative on that team?
Myself, our director of supportive housing, and our operations director of Hooper Detox were part of a task force meeting last Wednesday. So in short, yes, we are. I've just had one opportunity to attend, but we are at the table.
Fantastic. And then one other question, I know we're about ready to wrap up here, but somebody was asking if you could speak to the debrief process in clinical settings. This is from a nurse at Multnomah County, Evangeline Nichols. Clinic staff participate there in naloxone responses outside of the building in Old Town, but debrief is often a challenge given how busy the clinical setting is. I know we talked about that briefly, but just some perspective.
Yeah, absolutely. So Trevor and I had the opportunity as part of a cohort of leaders across the agency to participate in a critical incident debriefing training model. That model comes from a really incredible person and partnership in Montana. Andrew Lowy and Jennifer Buckley were the people who came and trained us. And it's called the STAR-T model of critical incident debriefing, if anybody is curious to look that up and receive a training from them. And that model really focuses on integrating somatically versus like cognitively critically traumatic or critically impactful events. I think one of the things that we're recognizing at CCC is both our capacity to implement those debriefings after acute events, but also the chronicity of the trauma. So, maybe one overdose that we respond to in community isn't feeling like it's critically impactful, but if we've responded to 10 in a 2-week period, that impact is going to build up. And so we've done kind of critical incident debriefing after 1 or 2 losses of participants, for example, after traumatic emergency responses, but then also kind of touching down with teams who have experienced a significant amount of loss or who've responded to a significant number of overdoses or other medical emergencies. And it does take time. And I think really what that requires is just a commitment from a leadership and administrative perspective to making time for that debrief. We always set them as optional. So for folks who feel like debriefing in community will be helpful, they're welcome to attend, but it's not mandatory for folks since everybody processes trauma in different ways. And we have a pretty steady group of people who are able to take time to facilitate. And it does take resourcing. It involves like about an hour and a half of sitting down and connection. And again, really focuses more somatically, more on the body's embodiment of the trauma versus like cognitively processing step by step what happened, with a focus on integrating the experience and being able to move forward, and also doing that in a community of people to bridge between kind of the isolation that can take over with traumatic events.
Someone had asked if you could just say the names again that you spoke. They said that they weren't able to write them down fast enough, or we can put them in an email on there.
Totally. I speak quickly and I apologize. It is Andrew Lowy, which is Laue. That's the person to Google, and it is the STAR-T method of critical incident debriefing.
Great. And then I think this last one here is less of a question and more of a comment, but I think it's a great note for us to conclude with here today as we let our extremely generous presenters back into doing their work. just someone put up a thank you for acknowledging that feeling of moral injury for folks who are working in this space. To be able to prevent or solve these issues of overdose and houselessness in our community, it can seem overwhelming. And today is just, for myself, I've been just really feel restored in terms of optimism and seeing that that work is being done in such a heartfelt and tangible way. I think there should be as much effort possible is to publicize and make people aware of this work. And just in my tiny ability as somebody with Care Oregon, I just want to again have the opportunity to thank you all for what you have done and for your continued partnership and make such a incredible impact and frankly just save so many lives. I just think it's remarkable, and we're very grateful for you guys. So thank you. And I think we're done with questions, and I know we have a lot of folks who are ready to get back to their day. So I wanted to say a brief couple things to close us out here today, friends. If you will just give me a couple seconds as we conclude our housekeeping. We do have another one of these sessions coming up in just a couple of short weeks. We are going to be focusing on hypertension management, basic practical methods to promote better blood pressure control, as well as chronic kidney disease. Incredible as it may sound, last year, the American Heart Association said that nearly half of Americans aged 20 and up, we're talking 122 million people, have high blood pressure. So it's a huge deal. It's a major risk for heart attack, stroke, dementia. So we've got some great folks from OHSU, Dr. Jose Rueda and Dr. Kate Gustafson are going to be our presenters for that session. You could take your phone right now and aim at that QR code and register for that session. We're going to be getting CME for that as well. That's already been approved, but it should be a really great session. We have not focused on hypertension, oh my goodness, since 2017 in MedZed. So it's overdue. And it impacts folks, and it's often very, very misunderstood. So I definitely recommend attending that session. It will be not what you expect, and I think it's going to be very, very interesting and impactful stuff. So definitely consider joining us for that one as well. And then beyond that, I just want to remind everybody that you'll be getting an email in just a few minutes from me that has the link to do all of your CME credit. If you want to be able to go ahead and fill that out, it's very brief. It'll have links as well to a copy of the slides available from today, and anything else that you need. If you have any questions, just be sure to let us know. Most importantly, thank you. I know how incredibly busy everyone is this time of year in particular as we launch ourselves deeper into 2024. A lot going on, but this was time well spent today thanks to our presenters and the great partnership we have with Central City Concern. The weekend's in sight. Hang in there, friends. Take care of each other and stay safe. And thanks for joining us this morning. I hope to see you all soon. Thank you.